The first session after lunch is uh, titled The COVID Pandemic, Unearthing Inequities in the Indian Health Systems and Lessons for the Future. I'd like to invite Dr. Balu Krishna to moderate the session.
Thank you. Welcome back after lunch. And going with the theme of the conference, Equity in Health, I feel the greatest disparity that affects health is wealth. And speaking on that, the economics of health, we have Dr. Tarun K George, who needs no introduction to CMC, but for those outside, Tarun is an alumnus of CMC and a professor in medicine. He is currently pursuing his PhD in economics of healthcare, especially in elderly, at University of Sheffield, UK. And Tarun is going to tell us about how COVID pandemic has exposed the inequities in healthcare, especially in the Indian context. We would listen to him, and then we will take some questions, and he would be happy to answer that for us. Welcome, Tarun, and over to you.
Hello, everyone. I'm Tarun K George, and I'm privileged to speak to all of you all at MAC 2023. A fond hi to our fellow students and warm regards to the virtual attendants. I'll be speaking on the topic revisiting the COVID-19 pandemic in India, but with an equity and economic lens, also looking at lessons for the future. The overview of my talk, starting at the bottom left, will be to look briefly at the Indian health system. Then we'll look at COVID as a timeline and see how different groups were affected. We'll explore the financial implications, the response to both the pandemic and inequity, and finally, take lessons that we can take forward. All along, we'll also explore some concepts along the way. I'd like to start exploring some concepts and terms. Unfortunate is unlucky, like COVID affecting India. Unfair and unjust are progressive and morally driven. It's unfair that those with physical disabilities cannot attend a conference because the venue doesn't have a ramp. Unlawful is illegal. To me, these lie along a spectrum of value judgments. Inequality in health is the differences that can be explained by a biological basis. For example, the height between races and the physical difference between unique groups such as the male and female sex. These cannot be corrected. Equality is linked with the term egalitarian, which forms the basis for democracy, where all humans are equal. But this refers to social value and political rights. The WHO refers to inequity as differences in health that are unnecessary, unfair, avoidable, and correctable. Unfair, avoidable, correctable. These unfair differences is disparity. Need is related to inequity. There are requirements everywhere. For instance, health worker shortages in industrialized countries or in urban areas in comparison to remote areas. There are requirements. But I propose that the unfairly disadvantaged group is where true need is. The response to inequity has to be collaborative. It has to be first perceived, as it may not always be evident. Society at large may not be affected by it and thus may not see it. Society needs the moral compass to judge that it's unfair. Appropriate action has to finally be aptly planned and delivered. Moving over to the health system, we realize that India's context is complex and unique. We often tend to compare it with Western, developed and high-income countries. The EU, for instance, has as many countries as India has states with less than half the population. Maybe it's more appropriate to compare it with China or the BRIC countries, but these also have different socio-political scenarios. So using individual countries as a benchmark, it's evident from these comparisons that India has a lot of scope for improvement. But it's also important to note that the trajectory, not seen here, has been quite appreciable over the past years. Now, looking within India, this infographic represents the distribution of wealth in 2018, with 1% of the population having more than 50% of the nation's wealth. One may question, is this fair? The second figure demonstrates the growing inequality during COVID, with high numbers moving from the low and middle income to the poor. Is this fair? And the answer, I think, is we may need more information, but this is to set you thinking. This chart represents infant mortality rate in India and differences between groups. Overall, there is an improving trend across time from the blue bars to the white ones, but there is inequity between the rich and poor, with and without education, and so on. One may argue that the differences in wealth may be justifiable because it may be due to drive, motivation, and hard work. But what about differences in health? Health is a right. It is a fundamental need, like education, to achieve one's potential. Without health, one cannot achieve wealth, and that is why it's fundamental. With this, we move on to exploring inequity among different groups. Recalling the COVID timeline, we see the first date of March 2020, where the lockdown was started, followed by the first peak. January 2021 was when vaccines were started to be introduced, followed by the second peak, and finally the third peak, all by different variants. I'd like to draw your attention to a study that we were involved in, and this is currently in the analysis stage. It looked at healthcare utilization during COVID in private hospitals in India. There were two umbrella organizations along with CMC, where we overall had information from 14 centers. This graph shows time on the x-axis along with percentage outpatient on the y-axis. The red line represents the first lockdown and the green the second. You can see that after the first lockdown, there was almost a 60% drop in outpatient services. And this wasn't the same during the second lockdown. And these represent a lot of hospitals. But as we disaggregate them, it becomes evident that different centers had different experiences. And this is unearthing differences. Were they fair or unfair? This is yet to be decided. Similarly, when we look at the trends across surgeries, immunizations, and ICU admissions, we see different patterns. The important question is, how were these impacts different for different groups? Rural, urban, young, old, men, women. And this is something we need to look into. Taking that concept further, I would like to explore the understanding of the social determinants which influence health. We start with the epidemiological triad, which we are familiar with, where there's an interaction between agent, host, and environment. And I'd like to focus on the concept of the dark green and white-head rainbow, where we see agents or individuals surrounded by lifestyle factors, further surrounded by social and community networks, all along engaging with their work and home environment and the general socio-economic, cultural, and environmental conditions. Thus, the agent may be inside the host or maybe outside, but they're all within the environment. The environment plays a huge role. How does this translate into ill health? Starting from the top left, one can see that social structures, beliefs, values influence the environment, and so does the material factors. They influence work, psychological, health behaviors. These can have psychological effects, as well as physical, morbidity, and mortality effects. All along, influences from the early life, genes, and culture can cause these changes. It's important for us to reflect upon these pathways in the way we see diseases around us in our clinical setting. We then move on to an important concept of vertical and horizontal equity. Horizontal equity refers to equal treatment of those with similar needs. For instance, the government may decide to incentivize health workers to work in rural areas rather than urban. Vertical equity recognizes that people with greater clinical needs should have more intervention. Here, the government may decide to set up a quaternary care liver transplant center for children with liver needs. This chart shows there's a trend of higher rural need where there are more number of cases in rural rather than urban across almost all the states in India during the COVID pandemic. But this reflects horizontal inequity because there is an opposite distribution of health workers. This study demonstrated that the age-adjusted standard mortality ratio increased with increasing age. With age on the x-axis and mortality rate on the y-axis, it's evident that as the age groups increase, the number of COVID deaths also increased, and they were differential across different states. This study shows us the influence of comorbidities and how, along with age, as the number of comorbidities increased, the risk of death also increased. These reflect vertical need, where increasing complexity needed more resources. And we saw this not just in our clinical response, but also during vaccination strategies where elder were given higher priority for vaccines. Returning to our overview, the next stop will be looking at the financial implications during the COVID pandemic. We start with a study which looked at the economic impact of COVID from the perspective of families seeking care in CMC. We looked at the 3 levels of care, level 1, 2, and 3, depending upon the oxygen requirement and ICU need. On the rows, the first row being the total cost, we captured the direct medical, non-medical, and the indirect cost, as well as the qualitative responses from the families. We note that the total cost ranged from 69,000 to around 2.6 lakhs. And this was driven by the direct medical cost, which was 66% in level 1 care to 91% in level 3 care. As we look at what drove this high hospital cost, we see that it was predominantly driven by oxygen as well as the drugs that were used during their stay. Now, it's important to pause and reflect, not just in COVID, but in many of our situations, how much of this cost is reducible. These were challenging times. Information was new. Responses were to be immediate. And the institution did offer concession to the final bill to about 15% of the patients. And all this refers to just the general patients. This ranged from about 35% for level 3 to up to 60% for level 1. But for the families that did get admitted, with a median income of about 2.4 lakhs, it's evident to see that this expense was catastrophic. In a very interesting community-based study, the mean out-of-pocket expenditure during the COVID pandemic was about 1.2 lakhs for seeking health. 25% of the community experienced a catastrophic health expense. As we saw in a previous slide, these expenses unfairly affect the poor more, and the government insurance schemes were crucial in mitigating further impact. But the question may be, how much do we expect governments to do, society to do, and the private sector to do? There is no free lunch, as the saying goes, and it's important to understand that anything that has to be given has to come from somewhere. In the case of the government sector, this is the proportion of Indians paying tax, and this is the current healthcare expenditure by the government. India is predominantly a private sector health-seeking society. Now, looking at both the government or a private insurance model, it's important to look at this cube, which is the universal health coverage cube. This cube has three axes. On the x-axis is the population who is covered. And when we seek from the government's perspective, the priority would be for those below the poverty line, the low, and then the middle class. As we expand along the x-axis, the others could be covered. On the z-axis is the services. Which services are covered? Would you start with maternal child? Would you progress to outpatient, inpatient? Would you then consider cosmetic, elective? And that is the services which should be covered. And on the y-axis is the cost sharing. Do you expect insurances to cover every aspect of care, 100% free at the point of access? Or would it be 50% and so on? This is important to think about as one expects different responses from both private and the public sector. And next, we move on to responses to the inequity. I urge everyone to reflect on how your institution and you as an individual responded. There was research which informed clinical practice, outreach, home-based care, which responded to the lack of beds, education to health workers, which responded to the inequity of misinformation and the dearth of knowing what to do. Technology such as telehealth responded to geographical needs. And I'd like to share the experiences of developing and being part of this study, where we looked at the cost effectiveness of COVID therapeutics for India. This is an economic evaluation that looked at patients with COVID-19 disease across the three severity states. And the comparators were different drugs for the severe and the non-severe group, which were demonstrated by the WHO PMJ COVID guidelines. We developed this model, which had an acute phase based on a decision tree and a chronic phase, which was a Markov model. And we computed this on Excel using a willingness to pay threshold of 0.5 GDP per capita. We took the Indian government's perspective to assess cost effectiveness. After inputting our costs, transition parameters, this table, which is the cost effectiveness of the non-severe group, shows the options or the drugs along the rows and the outcomes along the columns. As we take the deaths, certain the QALYs, hospital resources, costs, we create an incremental cost effectiveness ratio seen in the second last column. And we note that molnupiravir in this model scenario was the most cost effective option. It dominated remdesivir. Paxlovid was cost effective, but was higher than the willingness to pay threshold, and it dominated sotrovimab. These figures show the sensitivity analysis. The one on the right is the tornado graph, and it shows the variation of the ICER by changing the effects and costs of the drug. And we see that these were the two most influential factors on the cost effectiveness of the drug. Similarly, for the severe and critical group, we found that tofacitinib plus corticosteroids dominated all the other options. Now, there weren't any published guidance for the cost effectiveness of COVID drugs for India. But one can raise that from such a study, how would molnupiravir guidance apply for women? And that's a very valid point. Extending this kind of method further is one called distributive cost effectiveness analysis, where one may capture the benefits and harms to different relevant groups. And another type called the extended cost effectiveness, where financial risk protection for quintile groups may be ascertained. Hence, this just offers a view to make decisions. Another point that I'd like to impress is that while engaging to provide solutions, it's important to involve the stakeholders who are going to be the recipients of the research. In this study, we assessed or developed a choice framework for COVID vaccines in India using an MCDA or multi-criteria decision analysis approach. We started by developing a performance matrix, which created criteria across the different domains: clinical, economic, programmatic, political, and social. And we studied the performance of different vaccines across these criteria and domains. We then proceeded to engage with 3 different stakeholder groups: citizens, representatives from the private hospital sector, as well as government representatives, both central and state. During these interactions, we asked them what their preference was for each of these criteria and asked them to weight it up to 10. And this table represents an average of those weights. Using these weights, we multiplied it with the value and the performance of each of the vaccines, and this helped generate a rank order of options for the different groups. With the information available at the time, this proceeded to provide how different vaccines may be considered for the different groups. The point to drive home is that solutions towards equity involve engaging with relevant stakeholders, the beneficiaries, government, health workers, charitable organizations, pharmaceutical companies, and so on. Having provided you all with a bird's eye view of some interesting evidence and concepts that I have assimilated, the question is, what next? COVID may have abated for now, but our health and healthcare problems are increasing. Going forward, what could we do and who may take the lead? For governments or the private sector, it may be increasing the health budget. More health workers, greater investment in the public sector, increasing financing mechanisms to protect the poor who need, developing clinical guidelines, providing decision support in making better and informed choices, empowering and engaging stakeholders, leveraging technology, monitoring our disease or health focus, initiatives to deal with broader determinants of health, such as lifestyle factors. COVID was an opportunity to introspect. It's crucial that we go from it, but this journey is a long one. Now, these are such large issues. More importantly, what can any of us do about it, especially the junior colleagues? We entered this field of healthcare to make a difference. In various forms, we've heard God say, whatever you do for the least of my brothers and sisters, you do for me. It starts with you, the individual, your family, your community, then maybe the region, the nation, and who knows, even the globe. One is not more important than the other. Bigger is not necessarily better. It's just different. You may make a little difference in a big world, but a wonderful difference to the person in front of you. Seek your calling and do it well. It may be early years, but as your sphere of influence grows, you can make incrementally larger and more impactful change. Make it meaningful. Are you inclined towards fairness and need? If you see the unfairness, is it correctable by you? If you can't, what can you do to create the awareness? Can your research include an equity lens? Can you advocate? Can you be part of the solution? I believe each one of us can. Use such opportunities to expand your mind and heart. Discover the stories and the motivations behind the talks you listen to. Grow. Be the change you want to see. Thank you, everyone. My best wishes and fond regards. Signing off, Tarun K George.
Thank you, Tarun, for very lucidly explaining this and then also for that wonderful message to the future clinicians. I would probably take one or two questions from the floor, and then Tarun, are you there? If you can
Yeah, I'm around.
come online and take some questions.
Sure. Hello, everyone. Apologies about the quality of the audio. Obviously, there's a difference when we both sit in person and when we talk virtually, but hoping to make the most of this.
We are post lunch and we are talking about economics, which is quite difficult for us clinicians, but I would encourage one or two questions. Yeah, please. Yeah, while it happens, Tarun, let me ask you. I did work with you during COVID pandemic, though I am from oncology. You were leading the effort to reach out to public through the Udavi helpline that CMC created. If I were to ask you, since you're talking about economics, what would we have done, or what could we do differently if such a situation arises? Should our focuses remain the same as we did in the past, or do you think one or two parameters we should have looked in more to improve or avoid disparity?
That's a really excellent question. Thanks a lot, sir. And actually, I want to say that I was very much part of the team and a lot of teams, some of whom were led by Dr. Balu, Dr. Anandzai, and a lot of the examples that I've quoted reflect the work that a lot of our colleagues have done and are sharing. What could we have done differently? First, I think what was most interesting was to see the passion with which we responded. And I think this applies for a lot of institutions, for individuals, and even the way the city of Vellore responded. I think that passion was something for us to remember, recall, and remind ourselves that we have it. The urge and the willingness to push ourselves. So I think that's something for us not to forget, that there is a passion to reach out to those in need. I think what we could have done differently is break up into groups of where there is inequity. We often think of only economic inequity. We responded to it, and we did reach out to, for example, geographic inequity through maybe telehealth solutions, where a lot of our patients from across the country and even across the India and even outside the country needed to access our care. So we were reacting to geographic inequity. Were we responding to gender? There were a lot of evidence where domestic violence actually went up during the COVID pandemic, during lockdowns. Were we able to respond to that? And maybe we did, but did we talk about it to illuminate the others about it? Did we even think about things like, and I would expand those concepts of, if we were able to identify the different areas of inequity, we would have been more focused and channelized.
So I get it that we need to identify focus of inequities and then and make action plan for that in future. Sure. I have two questions from a gentleman over here. So one is a statement that only a small percentage pay tax is wrong. Everybody pays indirect taxes. Do you want to comment on that as a economics expert in health?
Fair enough. So that refers to 1.96 of direct tax. As was stated, 54% of tax is direct and 46% is indirect. So the point to raise is that, and I think it requires us to go down to the breakdown of those various gradients of tax. But I won't confuse the premise. The premise we feel is everyone is entitled, and I agree with that. But the point raised was there is a pool. All that amount goes to a pool. How much is going into the pool and how much is coming out to health? And we can't just equate one or the other. There are a lot of other responsibilities for any organization, whether it's private or public. So when we take the perspective of one group, we always have to think of the trade-offs. Where are we taking something from another group to give it to that group? And that was the message I wanted to convey.
There's a second part to that question, that the people do not prefer utilizing public health. Why do you think the community has that attitude? Or what do you think we should change?
So I think that's a very big question that has a historical basis as well as social preferences. And and it's very interesting because working in the UK and also looking at the perspective of public healthcare in high industrialized countries, there is an expectation or an accepted norm that public healthcare is of higher quality and more reliable. And it's very interesting because they are more questioning of the role of private healthcare. In India, we are heading to a situation, and we're already there, where we're suspicious of a lot of corporate private health. So you may expect quality in private healthcare, but are you expecting integrity? That is of question in a lot of private healthcare. Now, why is this happening? Has to look at how we've systematically invested in public healthcare and the role and responsibilities that stakeholders or individuals within that system have been able to reach the expectations of the public. And that has fallen short, and that reflects multiple reasons, but it is improving is what I feel. And similarly, the trajectory of private healthcare initially being for the benefit of people is also changing. So to answer that question, there isn't a simple answer. It requires investment from the government. It requires support from the private sector. It requires the people who are in those organizations to take leadership, to be accountable, to set up systems, and to involve and empower the citizens to hold us accountable. So I feel that all three groups are responsible.
Thank you, Tarun. I think you are one of them who's leading that effort, and you will find that answer in future. And from the floor, we thank you and wish you the best for your doctoral research in UK, and hope to see you back here. Thank you.
Thank you. Thank you, everyone.